Mittal is a good.
Ma'am, you may start, please.
Yes. Good evening to one and all everywhere. At the outset, I would like to thank all the founder members of Society of Indian
I'm sorry, the
Physiotherapists.
camera is not on, ma'am, yet.
Yes, 1 minute. The video isn't starting. Video isn't. Click on this thing. Start the video. Hello.
Ma'am, it's fine. You can start without the camera. It's okay.
Sure. Good evening to one and all. At the outset, I'd like to thank the founder members of Society of Indian Physiotherapists for giving me this opportunity to learn. Friends and my dear teachers, today we brainstorm into a very interesting aspect of handling children with cerebral palsy. We all know that cerebral palsy is on a rising incidence, which is in with its improved mortality. But always the morbidity has been into a question. Cerebral palsy, as my friends you all know, is described as a sensory motor disorder. Traditionally, the motor deficit has always been the focus of attention in assessment and treatment. The decreased movements, abnormal and compensatory patterns, poor postural adjustments have all been the most prominent features. So what does this lead to ultimately? Asymmetries, altered weight bearing, and inadequate somatosensory feedback, which in turn affects our body schema, motor planning, and cognitive development. This limited ability to movements limits our social interaction and interaction with the environment. And so to say, the end result is that they start with these inappropriate behaviors, such as inability to attend, learn, and to organize themselves. So when these children are referred to us, typically in our clinics, for inadequate head control, inability to sit, inability to move, or inability to stand, are these motor deficits the only contributing factors? Isn't not it truly a sensory motor problem that we are really looking at? Or are there some reasons beyond this also? I think to take this forward, I'd like to take the pleasure of introducing our first speaker for today, the young, dynamic, sincere, and hardworking founder member and treasurer of SIP. After completing his master's in pediatrics, the quest of knowledge and learning led him to certify himself as an NDT and an SI therapist in 2008. Yes, I'm talking of none other than our leading pediatric physiotherapist from Bhavnagar, Dr. Kaushal Bhatt. Welcome, Dr. Kaushal. Can we have?
Thank you, ma'am, for introducing me. Can I start with my presentation?
Yes. Yes, please, Kaushal.
Yeah. Good evening, everyone. Thank you, Urmila ma'am, for introducing me. And thank you, SIP founder members, for giving me this opportunity to talk on this topic. Mainly as a physiotherapist, I was working in with child with cerebral palsy from 2008. And when I did my SI course, something new has come out, like few children and cerebral palsy we are seeing in a different way. So today I'm going to share my views on this topic. first let me talk about sensory integration basic, because there are few people who doesn't know what is sensory integration or heard about sensory integration. Uh, this photo is Jean A's photograph. She said it is a process in brain. It is theoretical framework for understanding human behavior and a clinical framework for intervention based on A. Jean A's work, now which is registered as a AL sensory integration. Now, on which level sensor integration works? It works on from level of synapse, neurons, pathway, and reach to cortex. So, sensor integration occurs at the multiple level of nervous system. Now, sensory information, what we are getting, it guides to the behavioral development and occupational performance. So, as a physio, when we are seeing from the ICF perspective, our ultimate goal is a function. So, when we are getting good sensory information, it either good behavior and good occupational reach us to the good functional outcome. Now, traditional SI theory focuses on three main systems: vestibular, tactile, and proprioception. Yes, visual and auditory is important, but this is the main three systems SI theory focuses on. And here, SI cannot be observed. Although we observed deficit in behavior, we only hypothesize that these are result of poor sensor integration. Suppose we talk about the postural control, child is having wrong weight bearing pattern. So after seeing the behavior, this pattern is sitting is wrong or weight bearing pattern is wrong, we are hypothesize along with the tightness of muscles, we are hypothesize that there might be problem with the proprioception and tactile as well. So because of this behavior we have seen, we are hypothesize something. Okay, learning and behavior are visible aspects of sensor integration. You can see this picture. Why I put this picture here? Because every child is responding differently to the one sensory experience. See the facial expression of these kids. These all kids are behaving or expressing their facial expression in a different way. Now, there are some common signs and symptoms of sensory integration dysfunctions are hyperactivity and distractibility. Our child with cerebral palsy distract very easily in regular environment. Behavior problem, speech and language delay. Yes, we are able to see speech and language delay in our cerebral palsy kids. Main issue, oromotor problem, but along with oromotor, there might be oral sensory problems also. Muscle tone and coordination problem. This is what we are seeing as a physiotherapist. Tone and coordination in our cerebral palsy children. And learning difficulties at school, mainly child who is having JMFCS 1 or 2 or those who are going to school, they might be having learning difficulties at the later age. Now, how sensor integration works? We are working on the vestibular, proprioception, and tactile. And you see the end product here. See, arrow is moving here. So when we are working on the vestibular, proprioception, and tactile, eye movement, posture, balance, muscle tone, gravitation, security, seeking, eating is getting result on the second level. So when we are getting on the second level, on the third level, we are getting coordination on the two sides of the body, good motor planning, good activity level, good attention span, and good emotional stability. At the fourth level, we are getting speech, language, eye hand coordination, visual perception, purposeful activities. And at the end product, we are getting good concentration, organization, self-esteem, self-control, self-confidence, etc. So what is basic principle of interventions in sensory integration? It is we are giving some of the sensory experience and we are getting highest level of adaptive response, which is called sensory integration. And this we are doing in the context of play and therapeutic alliance. Now, I introduced about what is sensory integration. Now, sensory integration is divided in two parts: sensory dysfunction, uh, dyspraxia, and poor sensory modulation. Both are correlated. Because of poor sensory modulation, you might get problem in the praxis. I'm going to talk on sensory modulation, and my friend Manik Samnani is going to talk on praxis and dyspraxia. So let me talk about sensory modulation. When we see this chart, we are having problem in the vestibular, proprioception, tactile, auditory. What modulation problem we are getting? It is over responsivity and under responsivity. On the over responsivity, we are getting aversiveness and defensive reaction. Under responsivity, we are getting poor registration, and sensory related, we are getting behavioral consequences. We are able to see attention, regulation, activity problem, withdrawal, avoidance from the sensory experience. They are sensory seekers. This is behavioral consequences we are able to see in the child with cerebral palsy as well. Now, modulation of sensory input is critical to our ability to engage in daily occupation or in our ADL activities. To do any function, modulation should be good or it is maintained. Now, filtering of sensation and attending to those that are relevant, maintaining an optimal level of arousal and maintaining attention to the task all require modulation. It means when we started by 5 o'clock, okay, our attention is good, optimal, it is on the optimal level. But when time goes up, those who are not working in pediatrics, their level of arousal will go down. Now, attending the relevant stimuli, those who are working in pediatric and those who are seeing the cerebral palsy child regularly, they might correlate these things. Okay, we have seen this type of child and I have seen this problem in my child. But those who are working especially in the orthopedic field, for them, this is something new. Those who are not seeing the child regularly, it is something new. So that is not relevant stimuli for them. So they will filter it because that is not needed for everyday life, and maintaining the attention throughout my session. So for this, we need good sensory modulation. When modulation is inadequate, attention may be diverted continually on ongoing changes in the sensory environment. Something happens on my back or something happens in my clinic or in my house, I continuously keep looking at the other side. It means my modulation is not that much and I'm having inadequate attention to complete this functional task. We become distracted and attend all other inputs we are getting in our environment. So optimal level of arousal we are unable to maintain. Okay. Now, as I told you, sensory modulation divided in two parts: over responsivity and under responsivity. Under responsivity is mainly problem with the registration. It is a little bit difficult to discriminate between poor sensory discrimination and registration problem. And over responsivity divided in three parts: sensory defensiveness, gravitational insecurity, and aversive response to movement. Now, what is avoidance of touch? It means avoidance of certain texture, tendency to pull away from anticipated touch, avoidance of play activity with peer group and friends, and preference to sitting or standing alone. Now, aversive response to non-noxious touch means when someone picked up, hugged them, or cuddled them. Aversion and ADL activities like hair cutting, fingernail cutting, or bathing. Aversion of art material like finger paint, paste, or sand material we are using. An atypical response in the non-noxious stimuli, we can see the aggression to light touch, to arm, face, and legs, and increase the stress if somebody is close to them. And in the gravitational insecurity, it is excessive emotional reaction or fear that is out of proportion of real threat. Okay, gravitational insecurity I have seen in the so many cerebral palsy child, and especially when we are taking them on a ball, I will show you the videos. They are literally frightened up. Now somebody is telling like, okay, now that might be a new experience for them, that's why they are frightened. But to assess gravitational insecurity, there is test when leg is up from the floor and child is frightened. It is gravitational insecurity, and as soon as you put their leg on the ground, their frightenness or fear has gone down. So that is gravitational insecurity. An aversive response to movement, you can see nausea, vomiting, dizziness, and vertigo. I will show you the video of all these things. Sensory over responsivity, you can see negativity, you can see aggression, flight, fight, and response, and under responsibility they ignore input or fail to notice it. It means problem with registration. Now we are going to the cerebral palsy. See here, when we are having problem with the cortex, we are seeing the problem in spasticity, and sensory wise we are seeing the problem on the level of sensory regulation. When there is problem on the basal ganglia, we can see the ethetoid type of cerebral palsy, and we are seeing sensory motor feedback and feed forward mechanism. And cerebellum, we are seeing ataxic type of cerebral palsy, and we are seeing problem in the sensory processing. Uh, See this chart. I have taken one book, movement problem in the child with CP and their impact on sensory system. Uh, when abnormal muscle tone is there, you see the here proprioception. Proprioceptive input can't be used to modify the movement. That's why we are getting muscle tone. So when we are working on the proprioception, muscle tone might change. Now, adequate postural adjustment and abnormal movement pattern, tactile, restricted amount of input due to prolonged use of habitual movement pattern and decreased interaction with environment. So when we are giving different type of tactile inputs for postural adjustment and to correct the movement pattern, along with inaccurate feedback reinforce the movement pattern. So the right way of giving proprioceptive input also works to get a good postural adjustment and get a good movement pattern, along with vestibular, because reduce the variety of input due to decrease the movement. When head is not moving and you are not getting any type of movement in the neck and head, variety of vestibular input we are not getting, so they are having problem. Now asymmetries, especially we are seeing mainly in the hemiplegic, but other in the quadriplegic also we are seeing the asymmetries. Tactile feedback on the both side of the body affected by asymmetrical weight bearing. Feedback to the side of the body affected by asymmetrical weight bearing, and vestibular asymmetrical input received from asymmetrical position of neck or eyes intercept the movement. So tactile, proprioception and vestibular effect on the symmetries as well. And last one is inadequate weight bearing pattern. Poor alignment cause the prolonged pressure on the one particular specific part of the body and affects the input. Proprioception wise, poor alignment interfere with the weight shifting, proper muscle activation, and effects on feedback. So when we are working with a child with cerebral palsy, what surface we are using to treat, either we are using static surface or dynamic surface, we are always emphasizing on good weight bearing pattern, good movement pattern, good postural adjustment. That's why we are using different dynamic and static surfaces. So please make sure we are seeing the sensory modulation part along with our muscles as well. I'm showing this video. He's having aversion of movement. I was just taking him. He was hemiplegic. He was having GMFCS2. He was school going kid. And the way I told him he won't fall down. I was just holding him and he was also holding me. He was feeling that I will fall down. See this video, I was just taking him in ball, supine on ball, and he was just holding me. That time his age was 9 years. Okay, and he had gravitational insecurity. I was taking him on ball. He doesn't want to go up. I was just trying and trying. He doesn't want it to go up on ball. See this first video on middle one. This boy was having right side hemiparesis. When I took this video, his age was uh, 5 years, and he just standing on this wedge and he is crying. He doesn't want it to climb down. Therapist sitting in front of him is telling just climb down. He doesn't want it to move. Okay, he had aversion of movement problem, plus he had gravitational insecurity as well. This is the second video of him. Therapist is holding. from the left side, non-affected side, and we telling just climb down. He is crying. He is frightened. Okay. He just wanted to go down. He is okay on the surface, but when he is climbing up, he is having problem. When he is going up with with the foot grounded also, he is frightened. And this is third video of him. Therapist taken him on a ball, okay, and he was frightened. Leg was up on ball, it is not grounded, so he had gravitational insecurity. Now this boy went to school at the age of 6, and initially we were treating him for all physical issues, for hand functions, for leg, everything. When he went to school and when he was sitting on the bench without back support, he was unable to sit there, because when he was sitting on the bench, foot was not grounded, foot was up, and he was sitting there, simply sitting there, and he was frightened. Okay, he gone down, he was sitting in front of branch, sitting in front of teacher on the ground, but he doesn't want it to sit there on bench. So that time we found out that okay, he is having so many sensory issues as well. We worked on the gravitational insecurity, and emergence movement on the dynamic surface, and now at the age of 7 years he is okay now. He doesn't have any problem to go in school and sitting on the bench. What are the clinical observation we can see? We can see on this side, over responsivity, aversive defensive reaction, movement into backward space, jumping from a chair, touch applied to the back of the neck, response to touch during administration of postural tests. Under responsivity, we can see poor registration and fluctuating responsivity. Now question will come like how we are going to assess the sensory modulation. We For a sensory we are using SIPT, but SIPT doesn't play role in the diagnosing sensory modulation. For diagnosing sensory modulation, we are having sensory processing measures and sensory profile. Now sensory profile is available. This sensory profile to infant from birth to 6 months, toddler sensory profile 7 to 35 months, which have 56 questions, and you are getting at the end, when after you score it, you are getting seeking, avoiding, sensitivity and registration quadrants behavior, and sensory and behavioral section you are able to see general processing, auditory, visual, touch, movement, oral processing and behavioral issues you are getting. When they are under more than others, it means they are showing more than others problem on this specific quadrant or section. Child sensory profile is age 3 years to 14 years, 11 months. It's and question and answers. Seeking, avoiding, sensitivity and registration, 4 quadrants we are getting here. Sensory section we are getting auditory, visual, touch, movement, body position and oral sensory. Behavioral section, conduct, social, emotional and attention. Here only problem with sensory profile or sensory processing measure is this is parents questionnaire. So sometimes you are able to see that parents might be modify their answers, but yes, along with sensory profile, your clinical examination is best. This is one case study I have taken. This is a 4-year-old boy. No specific diagnosis. He had a history of developmental delay, problem in the fine motor grip, eating by himself using hand, fall frequently while walking, and parents labeled him as a floppy boy. Now you see here, see this section. Now avoiding coming in the 70, sensitivity here is a more than others. 45, registration is also problematic more than others. Here touch, movement, body position and oral sensory is more than others. Conduct and social emotional more than others, and much more than others. So here problem with avoiding also, sensitivity also and registration also. It means he is having problem in the sensory modulation. Sometimes he is showing avoiding behavior, sometimes he is showing sensitivity behavior, sometimes he is showing problem with registration. So this is a one example how we are using it. Now once we assess through this test I shown you or through sensory modulation, how we are going to treat it, treatment guidelines. This is few examples how can we treat it. For sensory over responsivity. If they are having sensory defensiveness, moving in the large ball pool, crawling under textured pillow, we can do it at home, painting and drawing with shaving cream, foam soap, and finger paint, finding object hidden in a bag filled with the rice or bean or big bean bag you can take or put something inside and let them check it out, or take a big ball of rice, hide something inside and let them find small toys which is there inside. You can use the 1 or 2 point swing, slowly and rapidly on the swing suspended, and engage in the different play activities, jumping up and down on a trampoline, falling from crash pad from stationary object or moving swings. So falling on crash pad from swing or from the ball. Same thing you can use on gravitational insecurity, bounce up and down while seated on therapy ball. You see, first your feet should be on ground initially, bounce on swing, therapist sitting behind on child, okay, and you must be having bouncing rope, swing is hanging, bounce up and down or pull cord while seated on platform swing, okay, they are bouncing and they are pulling the thera tube what we are having in our clinic. Ride prone on scooter board on floor and thus pull or push the thera tube or any elastic material which will give proprioceptive input as well. Throw a ball at a large target while prone in swing, which is give very good vestibular and proprioceptive input. Swing back and forth while sitting on balls to swing, okay, and do some playful activities. The treatment guideline for sensory under responsivity may have fewer muted or delayed response to daily sensory event. When you are checking the sensory or when you are checking the tactile and cerebral palsy, they might have not responded, they might have responded very slowly. So just wait for a response. They might be having very slow response to your tactile or vestibular response. Give them a time to respond and check, okay, and difficult to distinguish between poor discrimination and under responsivity because both can lead to the challenges with fine motor and gross motor activities overall in general in which we are working, okay. So give them a time, let them respond and work on that. Give frequent opportunity for enhanced sensation in order to reach sensory threshold using any or all of the sensory system that is upon your clinical experience. Either you are giving vestibular, tactile, proprioceptive together, or when child is having small, they are responding very slow, either give tactile or give vestibular or proprioception one by one. So this was few ideas. I put it down for sensory under responsivity. Thank you very much. This is the references book I have used for my presentation. Third edition of Sensory Integration, Anita Bundy and Shelley Lane. Sensory Integration and Child by Jean Ayers, and Neurodevelopmental Treatment and Sensory Integration Combination by Anna Blanche and T. Thank you very much. Urmila ma'am.
Thank you, Kaushal, for that very beautiful, excellent presentation. We just need to understand here. Just let's pause for a minute and understand what is the age at which we are really, my video seems to be not understanding and having some modulation issues, looks like, or registration issues, whatever. So anyway, we will continue.
Yeah.
So let us pause for a minute. We have understood that we've seen two children. You saw the modulation disorder in a child with 9-year-old, and you also saw a child at 5-year-old. Has all this started overnight? What is the age at which these issues have developed?
Now we can see from the infant stage as well.
Yes.
Okay.
So what I was talking here, Kaushal, was we are all of us who are working in the NICUs would definitely agree with me when I say that this is what we see typically in babies when we start handling them. So as infants, they either are very highly irritable or they are not in a, they are kind of shut down responses.
Yes.
Do we think that this is an under responsiveness or an over responsiveness? Are we seeing the difficulty in modulations right from that very infancy stage?
Yes,
then
ma'am.
then the whole gamut is changing, and we are understanding. And let us now think, what is the primary issue, whether it is something which is a sensory issue, which is a first, or it's a motor issue, and whether how do we need to tackle this. So i
Thank,
think I think we let's keep our audience also in this, but let's move ahead. Kaushal, thank you for that very great presentation.
thank you, ma'am.
uh, I Let's move on to the other deficits in sensory procession. All of us know also affect the ability to process the information from the body, from the space, and the objects too. And to highlight, we are privileged here to have our second speaker, a fellow professional whom we all in pediatrics work hand in glove with. I'm sure all the people who work with my team members, we know the importance of all our team members. And I would really like to welcome here Dr. Manish Samnani, who's the Chief OT and Director of SOCH. He graduated in 2000 as a certified entity SI therapist and at present pursuing his PhD. Manish, I'm very happy to tell you all that he has received the Professional Excellence Award from AIOTA for the year 2020. My heartiest congratulations to you from SIP, and welcome Manish, over to you.
Good evening, everyone, and thank you, the entire team of SIP, Dr. Kamath, Dr. Bansal, Dr. Kaushal, to invite me and to be a part of this wonderful program and a topic which is so interesting because typically we understand SI as a different disorder completely relating to other conditions rather than really looking at it from a condition where it can be completely correlated with the motor dysfunction as well. And studies have shown from time and again that the motor and the sensory dysfunction cannot be really separated out, and it has to be assessed and treated together. So having said that, let's go to the topic that we have today, and I'll start with sharing. Okay. I hope the screen, I hope my screen is visible. So the topic or the second part of the sensory integration is after completing the sensory modulation, we come to the dyspraxia in children with cerebral palsy. Now, what is dyspraxia is the difficulty in the praxis. However, we should understand what praxis is first to be able to understand what the difficulty would look like, how it would be assessed and treated. Now, praxis is uniquely human, and it is relating to the brain's ability to conceive, organize, and carry out a sequence of unfamiliar actions. So the important aspect here is unfamiliar action. The important part here is it's not just about executing an action, it's about conceiving an idea, organizing it, sequencing it into smaller parts, and then actually executing it. In order to understand this definition, I would like to take an example of cycling. Remember when we were learning to cycle and we haven't really learned completely to balance on our own, and we were still figuring out how this balance on the cycle, the pedaling on the cycle will go together. Your brain was really challenged to use the inherent or the developmental praxis abilities. However, now if you are an expert at cycling, if you cycle now, it would mean that it is not an unfamiliar or non-habitual action, and hence not much of a praxis will come into action for a person who is cycling, who already knows cycling very well. So remember that praxis is relating to unfamiliar actions. what does the dysfunction in praxis look like? The dysfunction in praxis, one is almost always has an underlying sensory integration pattern. The dysfunction in praxis can have two different patterns. One is called as the somatodyspraxia and the other one is called as the bilateral integration deficits. The somatodyspraxia relates to the underlying difficulties in the tactile and proprioceptive processing difficulties. The manifestations of somatodyspraxia may or may not be only physical aspects or motor and can be seen in what we call as clumsiness. Sometimes clumsiness is regarded as a behavior of the child. If the child is really accident prone, he has enough motor abilities and motor functions, but is quite accident prone and is bumping and tripping on objects. If he has difficulty in constructive play, which means he has some difficulties with how to play rather than in the physical aspect, rather than in all other aspects of conceiving and sequencing it. Fine motor problems. A lot of times, if you see children having difficulties with fine motor, pencil holding and writing, holding small objects, manipulating, you might want to look at those difficulties not just from the neuromotor kind of a aspect, but also from the fine motor kind of an aspect, or from the somatodyspraxia aspect. And you would like to assess the underlying SI dysfunction. Poor handwriting, again, correlating to the fine motor and also correlating to underlying tactile and proprioceptive processing difficulties. Imitation difficulties. Here are those difficulties where the examiner or the teacher frequently finds a child not able to initiate a motor action, even if the modeling of the action has been done, even if the child has enough neuromotor abilities to be able to copy the physical action shown, demonstrated to the child. Let me show you a video of a child who may not have cerebral palsy, but just to understand how this dyspraxia would look like in a child who has this kind of difficulties with imitation. So let me show you a child just to show you first that he has enough motor and abilities to understand the command as well. Here is a child who was given instruction. So here is a child who knows, who understands the command, has the necessary language to understand those commands. But when the same child was then given some imitations relating to his body parts, relating to his body actions, this is what the response was. He has understood what is supposed to be done. As you can see, he really struggles. As you can see, he really struggles with following up those instructions and is not able to imitate or copy those actions shown to him. Now, the second aspect or category of difficulties in praxis difficulties is about bilateral integration. Now, these category of activities are those where the child would have difficulty in using two hands at the same time. He would also have difficulties in anticipating, or what we call as the projected movement sequences, or timing his motor actions, which means that if the object is in motion, say catching a ball, then this child might have more difficulties than doing other usual physical activities. We can see how the bilateral difficulties look like again through a video. Now here's a child who was making a tower. And what we need to see is whether the two hands come together at the same time or they come a little differently. As you can see, the other hand is uh, away from the object. One of the hand is busy applying the objects, whereas the other hand should have been helping the child. As you can again see, the other hand, one hand is placing the object, but the other hand is really away from the object. This is again very unusual because this is a difficulty with bilateral integration, and this is also difficulty with timing the action in the appropriate time. You would have also seen that the child picks up with both hands. When the object is on the right side, he picks up with the right hand, and when the object is on the left side, he picks up with the left hand. He does not cross the midline, and he does not cross over and pick up the object consistently with the dominant hand. He uses both the hands at the same time. So he has difficulties with bilateral integration, and he has also difficulties with timing. How do we assess the praxis kind of difficulties? There are some standardized tools available: sensory integration praxis test, which has four subtests: constructional praxis, sequencing praxis, praxis and verbal command, and oral praxis, to be used as the subtest of specifically for praxis difficulties. As far as somatodyspraxia is concerned, it correlates and is assessed very frequently in the literature by doing tests of tactile discrimination. You would be aware of tests of stereognosis, the Moberg pickup test. The 2-point discrimination test also correlates very strongly with the somatodyspraxia kind of difficulties as performed on even children with cerebral palsy as well. The other common observation that usually sensory professionals do is about their non-congruent motor planning and execution of movement, which means that even if the child has difficulties, does not have difficulties with the execution of the movement, his neuromotor abilities might be fine or are recovered or are enough strength is there to do the action. Very frequently, children with dyspraxia will have functional difficulties in their day-to-day life. What that means is that even if your child has improved significantly as a part of therapy in the early developmental years, you would see that by the time he should have been independent in his day-to-day daily activities, dressing, brushing, or other ways, he still is struggling and is not able to use the strength and other neuromotor functions that he has already acquired in his day-to-day life. Whenever that kind of a non-congruency is seen, you should be able to see it from the light of praxis difficulties. There are some components of praxis that are important as far as assessment and treatment is concerned. The ideation, the anticipation, timing and sequencing, sometimes also correlated or used synonymously with motor planning, initiation and execution. Now, ideation is the ability to generate idea and is definitely relating to cognition in CP. That means the better cognition you have, the better ability of you will have to generate the ideas. And if the child has good language communication and good cognitive abilities, probably he would have very good ideation as well. So we assume that there might be children who may not be able to do physical actions, who may not be able to do day-to-day functioning of the activities, but if they are able to generate good ideas, if they're able to tell us how that action or how that activity or functional activity will be performed, if just in case we ask the child, how do you even know what are the steps of those tasks, can you break down the steps, can you break down the bigger functional activity into smaller steps, then, and if the child is able to express those ideas, then probably he does not have difficulty with ideation, even if he has difficulties with not being able to do that action actually in his life. Children with ideation limitation might use objects in a very simplified way and not in an age appropriate way. And I will be, I would again like to show you a video of a child with cerebral palsy who uses, uh, who uses a ball in a very different way. And I would like to share with you, what does he do with the ball? So here's a child who has a ball and he's fascinated to the ball. He loves it. He wants to always have the ball in his hand, but this is what he does with it. As you can see, he licks the ball. He hits the ball on his head. He hits the ball hard on his face. He hits the ball repeatedly on his mouth. It looks like he definitely wants the ball in his hands all the time, but his ability to use the ball in a meaningful way either is still not developed or is just not there. This is his ideas of using the ball. Lick the ball, put it in the mouth, eat it, hit with it. You could also say that he's actually doing self-hitting. And not just licking, he's actually doing self-hitting on his mouth and face using the ball, which means that his ideas are not very age appropriate. Treatment of these children who have difficulties with ideation might involve using sensory integration approach as it would be used with any other child having only aside issues. And we would also be using cognitive approaches with these children because for their ideation is so closely related to cognition. Sequencing and motor planning is the ability of the child to sequence and motor act in a step-by-step way. The most common example of looking at sequencing and motor planning from the assessment point of view is to look at the child while he is doing obstacle courses. If a child is not able to figure out how would he manage obstacles while walking, or how would he manage those obstacles even if he has learned to walk independently, if he does not know how to make his way across the obstacles, then probably he has difficulties with sequencing and motor planning. This sequence motor and difficulty is very commonly seen in children with hemiplegia. And although children might learn to walk, they still are not being able to walk in the community because they have difficulties with praxis, they have difficulties with sequencing and motor planning around the normal, natural obstacles that they will find in the community. Again, treatment of such children is not by neuromotor or not just by neuromotor approaches. In fact, it would be the SI approach that we would use for children with other children with sensory processing disorders purely, to be used with these children. In this case, the children are given graded obstacle courses. They are given time to process the information of tactile and proprioceptive to figure out a way. They are deliberately challenged, they are deliberately given challenges around which they will have to come across in a play way inside a therapeutic or clinical environment to be able to come up with their abilities or develop their abilities of motor planning. Anticipation and timing relates to the feed-forward mechanisms as opposite to the feedback mechanisms that typically we use in our activities where movement of the object or movement of the person is not involved. In feed-forward mechanism, the body has to uh, anticipate and do certain calculations relating to spatial and temporal accuracy even before the motor action has been actually been executed. These are activities which are fast, these are timed actions, and they are frequently seen to be missing in children who have these difficulties. For example, jumping jacks might be difficult. Kicking a moving ball versus the child might have, it might be easy for the child to kick a static ball, but the child has difficulty kicking a moving ball. That would show that the child has difficulties in anticipation and timing. uh, Let me again show you a video where we are asking a child to do jumping jacks. He has good good neuromotor abilities, although, but just for our understanding of or our clarification of these things. So here is a child who was told to do, he was shown how to do jumping jacks. He was told what is to be done, and this is what his performance looked like. So he has huge difficulties with the coordinating the both sides of the body. He has difficulties with uh, timing and sequencing those actions, and hence is not able to do it despite having good motor abilities. Execution is a final expression of praxis. It is said that all children diagnosed with CP will have an execution problem because of the underlying neuromotor problem. Execution is the expression of the praxis. It is the final ability of, this is what is observable, and hence the other aspects, ideation, motor planning, anticipation and timing, become more important to be assessed because they are all hidden. Execution is something that will come naturally to your eyes, and you would be easily able to say whether the child has an execution difficulty. One of the commonest example that is given to assess children having execution difficulties and the other motor planning difficulties is that if a child has good ability to conceptualize an action, he is able to tell you the steps verbally or in written or in a pointing way. He's able to tell you what is it's supposed to be done, but actually cannot do it. Then maybe this child has more of an execution problem rather than the problems with the praxis. And the other way around could also be true, whether the child where the child has good execution abilities, he has good neuromotor recovery, he has good outcome out of the therapies, but he still has severe difficulties in his day-to-day functional abilities. In that case, then we should be thinking about praxis as the primary problem rather than the recovered neuromotor difficulties. Children with difficulties in praxis are frequently seen to participate in using the equipment of the clinic, say climbing on a swing, climbing on a static ladder, in which case it is seen that if they have a praxis problem, they might be able to get on the swing, but do not know how to get down from the swing. They know how to climb up the ladder, but they still can't figure out. They're confused about what would be the steps to be followed to get down from the ladder. So this was about the praxis difficulties in children. If there are any questions, we would be able to take up those now. Dr. Kama?
Can you get my, yes, can you get my video?
Yes, yes.
Yeah.
No, I cannot see your video.
Sure.
I can hear you.
So
Yes.
I'm going to have the question answers with
Yes.
you and Manish Kaushal both. Okay. Kaushal, can I have the questions for you first, please?
Yes, ma'am.
Yeah. So the first question which really I would ask you is, can you correlate? We've seen SMDs and pure SI dysfunctions. Yes, we all agree with it. But I would like you to correlate the incidence of modulation disorders, taking into consideration the different GMFCS levels.
Right, ma'am. There are a few studies, especially one study I have got in 2017 published in Journal of Korean Society of Physical Medicine. It stated that sensory difficulties increase with the level of GMFCS and MAC increase. So when GMFCS 3, 4, 5, GMFCS level increase, sensory difficulty increase.
Yeah, I agree. We are also looking at, but at the same time, also, can you
Yeah.
correlate it with the type of cerebral palsy that we see? Is there any difference there? Is it less in some? Is it the other way? What are you really looking at in
Yes,
terms of?
ma'am. Especially in the movement disorder like etexic and dyskinetic type, they are having more problem. And spastic hemiplegic, they are having touch processing. Spastics are having less problem compared to the dyskinetic type. But when we
Hmm.
are compared between the spastic type, there are diplegic and quadriplegic subtype having more sensory modulation difficulties than hemiplegic group.
Okay, okay. See, physios cannot ever end a session without asking about gait.
Yeah.
So, have you come across any literature which correlates SMD and gait? And does it have any particular effect on any phases of gait? Or how does it make it more
Uh,
relevant to our topic today?
There is very less studies on SMD and GATE, but I got one studies published in 2000 in American Journal of Occupational Therapy by Sue et al. And they checked sensory modulation disorder and on the not cerebral palsy child, but on normal child, a typical child. And they found out that stance control was impaired. They are having gait issues. Okay, so definitely in our cerebral palsy child, we can correlate that.
I think it opens up a huge arena for all our projects or masters or anything and research. So I
Yeah,
think it opens up a huge arena for us here.
yeah,
And you have spoken in your presentation about the SIPT and everything.
yeah.
As it's not, you may not be an SI certified at every place in the clinic. Not all are SI certified. Would you recommend any particular test quickly to be done so that at least we have in partial the modulation disorder diagnosed? And then, of
Ma'am,
course, you go for a formal testing. There's no bypass to it. There's no question about it. But yes, is there anything that you would like to add on this, Kaushal?
sensory profile proved good, though we cannot say it is a gold standard because it is always being a parent's questionnaire. But there are studies which state that sensory profile shows good sensory, they can guide us to sensory modulation problem in cerebral palsy. And let me give you a few data from sensory profile in quadrants and sensory section. Mainly in the all type of cerebral palsy, registration is problematic. Okay, and when we are going to the ataxic, dyskinetic, and spastic diplegic, body positioning in sensory section is problematic. Spastic hemiplegic, touch processing and visual is more problematic. So overall, SMD in cerebral palsy, we can see from the point of view of sensory profile, quadrant registration is 72.73 percentile and avoiding 53 percentile we are able to see. This is, I'm talking about overall cerebral palsy. And sensory section, body position 77.92 percentage, movement 56.49 percentile, and visual processing 53.25 percentile. So this is the range we have got in cerebral palsy. So definitely we can use sensory profile to get the sensory modulation problem in cerebral palsy children as well, along with our clinical examination. Because as
Oh,
I said,
that's absolute. I think this complete sensory motor assessment is what we really need to comprehend too.
yes,
And also, I think I came across a very interesting study for the benefit of everyone that there is some study which is used for the master's program, and in this it was stated that almost more than 40% of the children with cerebral palsy have shown up the SMD problems, the this thing, so
yes,
sensory modulation disorders. So I think we really need to look into it into depth. So thank you, Kaushal, for that excellent presentation and with very quick questions
okay,
and answers. Thank you so much. If there are any questions, I may ask you further.
yes,
Can I move over to Manish, please? Manish?
Yes, please.
Yeah. Manish, there is a question which I would like you to address, which is from the audience. And there is a question. In the child, the video that you showed, hitting the ball on the face, right? The child was
Yeah.
constantly hitting the ball on the
Yeah.
face. Now,
Yes.
they would like to know how would you differentiate it's because of lack of ideation or because of sensory seeking behavior? Is it a sensory seeking behavior or is it a lack of ideation?
Yes. So one of the very, it's actually a very good question. You know why? Because the sensory seeking that we typically tend to use a lot in our day-to-day professional interaction, interaction with our parents. In fact, sometimes parents themselves also come to us and say, my child has a sensory seeking behavior. The sensory integration frame of reference does not consider sensory seeking itself as a construct of sensory integration. What that means is that they consider sensory seeking as just a behavior. They always say that the sensory seeking will have an underlying sensory integrative dysfunction, which means that the child with this kind of a behavior is there. You can kind of note it down that the child does this, and you can explain it in terms of philosophy that this is sensory seeking. However, when it comes to clinical reasoning, you have to look at it from the point of view of either sensory modulation disorder or a praxis disorder.
Thank
Sensory
you.
seeking in itself is not a real problem.
Thank you, Manish. I hope it satisfies the person who's asked it. Okay, the next question for you is, what is the incidence of, see, we are seeing a lot of clinical practice. We see a lot of children, typically developing children also, who are on that average IQ, sometimes they do not. And we see a lot of dyspraxia in the typically developing children also. The other group is a pure SI dysfunction. Have you come across any research article or any studies which talks of incidence of dyspraxia associated with cerebral palsy typical as a contrast in these categories?
So what they say now is, like you had also had I think a reference to a study which says
Yes.
that the sensory dysfunction is correlating to the white matter lesion,
Yes.
which is again correlating to 45% of children with cerebral palsy.
Yes.
We can, in that way, we can assume that at least 45% of children with cerebral palsy would have some or the other sensory dysfunction.
Yes.
However, how much percentage of children would have a praxis kind of a difficulty or a module versus a modulation difficulty is something that still is still to be researched in that kind of a differential way, because there is
Right.
such an overlap between these
Absolutely.
difficulties due to neuromotor and due to underlying SI dysfunction itself, that it might be actually difficult to study how much of it is because of a neuromotor problem or because of an underlying SI problem.
Thank you, Manish. My other question is there a difference where dyspraxia remains dyspraxia? Now, clinical, as a clinician, how would you differentiate between a dyspraxia seen in a child with an SI dysfunction as against a child with cerebral palsy? Is there any difference in the first place? If yes, can you just explain it to us further?
Yeah. So one of the primary thing that comes to discriminating dyspraxia in these two populations is about their ability to get back to functional abilities. What I mean is that children with other or primarily a SI dysfunction, let's say autism or ADHD or learning disability, typically have underlyingly good neuromotor abilities, and they do not have much of a severity with the day-to-day functioning, their daily living activities, unless and until they have a comorbid ideation, cognition kind of difficulties. So they usually are doing pretty well with their day-to-day activities. They might have difficulties more with their attention, with their arousal levels, with their difficulties in sensory modulation, which makes them either seek more sensation or try to avoid some sensation. They might run away. They might show fight and flight responses. Children who are underlyingly only purely SI dysfunction. Children with cerebral palsy would always have SI dysfunction expressing itself more as something beyond what can be attributed to their neuromotor problem. What that means is that even if they have enough motor abilities in a particular setting, they are not able to use those same motor abilities in another setting. It is quite contrast that when the setting, environment, context changes, their performance of similar or same motor action drastically goes down. So in children with neuromotor dysfunction, I would say the primary problem that you would see due to underlying SI dysfunction is again a motor dysfunction, but more in terms of not matching or not being generalization. is a major problem with children with cerebral palsy when that is due to an underlying SI dysfunction. Of course, they also show the sensory modulation kind of disorder, where they might be too sensitive or too aversive about certain sensations. They might be very apprehensive about certain sensations. But typically it is being correlated more and more with their functional independence, their ability to actually translate those individual motor actions, which they have learned now. They have learned to do flexion, extension, abduction, external rotation. But when it comes to transforming them into a day-to-day life, say brushing your teeth, the kind of motor actions that you would see, it's a more of a combination of certain mid-range actions there, and they are not able to actually do it, or they are hugely dependent in those activities, even if they have good individual motor actions.
Okay. Often we see these parents who are confused when there's a left hemiplegia, right hemiplegia dominancy. So I'm sure you must have come across a lot of these children. My question to you, Manish, here is, does dominancy have any effect, or change of dominancy for that matter, does have any effect on the practicabilities of a child?
I would say that is again a very important and good question, because sometimes the dominancy is not really viewed as something very important and valuable from the developmental perspective. We assume that the child would be either right dominant or left dominant on his own. We assume that one, or second, we assume that even if the child is somehow using this hand or sometimes using this hand, like we saw in the video, we assume it as a more strong or positive ability of the child. Actually, the reality is just the opposite. If you have a child who does not have a clear hand dominance, he's inconsistently using right hand and left hand for the same task, which is the sign of inconsistency, then we assume that this child actually has a difficulty with developing the laterality of the brain. He also has difficulty with coordination of the left brain with the right brain. And if he has difficulties with laterality, he would have difficulties in specializing certain functions of that particular hemisphere. And when he has difficulties in specializing the functions of that left or right hemisphere, he would also have difficulties with the praxis. Because praxis is about using both sides of the body. It also is about timing of the both sides of the body, like catching a ball. If your one hand comes in action, but the other hand does not come, you miss out the ball, not because you did not know how to catch the ball, but actually your two hands actually missed each other. And if they miss each other, you will not have a good ability to do it. Sometimes it is confused with eye-hand coordination. Sometimes it is confused with the child actually not being able to catch a ball because he has lack of practice. But in reality, if you assess these children very closely, or make a pattern of certain right hand, left hand coordination difficulties in his other day-to-day activities as well, we might very frequently see that these children actually have praxis difficulties.
Okay. I'm just attempted to ask one more question, since you answered this question so well. Is there a cutoff age that you would consider this? Is there an age limit where you would want this established?
Sure. Yes. Again, a very good question. By 2 years of age, we say that a child should have a clear hand preference. Now, remember, hand preference is different from hand dominance. When we say hand preference, the child will still might use the other hand for certain activities. But if you ask a parent, do you think he's right-handed or left-handed? Usually they have an answer. Just in case at 2 years of age, a parent does not have an answer of whether they think the child has right dominance or left dominance, even if the child has a mix of the two behaviors, then you would start thinking that this child still does not have a developing clear hand preference. The clear hand dominance develops by as long as 7 years of age, which means that till 2 to 7 years of age, a child might use the other hand inconsistently, sometimes infrequently, but is not frequent enough to get confused, or it is not confusing to the teacher or the parent to give us a clear answer of which hand is dominant. And if you ever see a parent saying, you know what, he uses both his hands, you know that there's something with their dominance thing already, which you might also see in your activities. So you have to correlate with your activities in front of you, deliberately place the objects on both sides of the body, See if the child actually is not crossing the midline and is using both hands as a dominant hand, one at a time, and you are and correlated with parents' confusion about it, then you would know that there is definitely a difficulty.
Thank you, Manish. Thank you very well. You have answered very well. Thank you so much. Well, to summarize, can I think, Manish, the questions are now over. Can you stop sharing your screen, please?
Sure. Oh, okay.
Thank you so much.
My screen
Thank
is...
you. Thank you so much. So the motor constraints, so summarizing everything, let's once and for all go. The motor constraints limit the performance of activities, which provide us with tactile, synesthetic, discrimination, and proprioceptive sensations. These constraint abilities, basically, they don't allow the children to explore and have an impaired mechanism of perception and modulation of sensory stimuli. This restricts the ability to modulate their emotional and behavioral responses, or rather, do not get a striking balance between habituation and sensitization to stimuli. Thus, all in all, we see that cerebral palsy exhibits inappropriate responses to the environment. And thus, this has also been the motor control theories also are now correlating very well that movement and sensation are related. So, my dear friends, this is what my both speakers, I think, had to summarize today. Thank both my speakers for such an excellent presentation. And friends, as a concluding statement, suitable sensory integration promotes functional performance. We, as movement specialists, need to incorporate these principles to all our patients, be it children or adults, because key to successful intervention lies in successful detection. I would like to thank one and all present today. And if any questions are there, or if the time permits, I will ask Dr. Nitish if the time permits, or I think we can conclude this session.
Ma'am, we can conclude it now.
Thank you so much. Thank you, everybody.
Thank you.